Hey everyone, and welcome back to the channel. Just in case you're new around here, my name's Khaled and I'm a final year medical student. In this video, we're going to be taking some scenes from Grey's Anatomy and breaking them down for you. Hope you enjoy it.
A month ago, you were in med school being taught by doctors. Today, you are the doctors.
No one really talks like that. I've never really heard a speech that dramatic in medical school or even the hospital. Seriously though, it is an interesting thought that always crosses my mind to finally become a doctor when you've been studying for so long.
Hi, I'm Isabel Stevens, but everyone calls me Izzy.
I have 5 rules, memorize them. Rule number 1, don't bother sucking up. I already hate you, that's not gonna change. Trauma protocol, phone list, pagers. Nurses will page you. You'll answer every page at a run.
Pagers are really important. Being the student that I am, I never really had a dedicated pager, but when I was rotating 1 month in pediatrics, they gave me a pager on my on-calls, and it will be absolute hell if you do not respond to your pagers.
Your first shift starts now and lasts 48 hours. Your interns, grunts, nobodies, bottom of the surgical food chain. You run labs, write orders, work every second night until you drop, and don't complain.
A 48-hour on-call is incredibly taxing on the human body. I don't think they do that anymore for the simple reason that burnout can cause physicians to start making mistakes, and when mistakes happen, patients' lives are at stake.
We got no wet fish on dry land.
Absolutely, Dr. Berg.
Dr. Bailey, let's shotgunner.
That means every test in the book, CT, CBC, Chem 7, tox screen. Christina, you're on labs. George, patient workups. Meredith, get Katie for a CT. She's your responsibility now.
This is a bit extreme. Patients don't usually get shotgunned. Shotgunned means you order pretty much every investigation and hope that something sticks and you can use something to follow up with other investigations. This is not really how you approach diseases or illnesses within medicine. When patients present with complaints, you can use certain clues from the history or physical examination in order to guide your management and get the appropriate investigations. Here, it doesn't really seem that they actually did any history or any physical examination. They didn't really get any clues. All they know is that this otherwise healthy, young girl is having new onset seizures. It doesn't mean that you can just order every single investigation because first off, that's ineffective. Secondly, it's costly. And third, it's just not what good doctors do. Shotgunning could be effective in certain cases, but this is definitely not one of them. They should have at least gotten a full history and physical examination. Sometimes surgeons tie knots in the operating room with their hands, and they do it in a very complex manner with a series of gestures. The reason they do this is because of a principle known as the economy of movement. Think of it as if you're sitting in a car and you have to use your gas economically to go from one city to another. You're going to use your gas in such a way that you'll complete the trip without being stranded in the middle of nowhere. Similarly, in the operating theater, you want to use your energy in such a way that allows you to complete every single surgery without running out of energy. Therefore, there's a standard for how you can tie knots with your hands in order to use the least amount of energy.
What are you doing here?
Katie Bryce's labs came out clear. There's nothing in the results that explain her seizures. I just thought you want to know.
Okay.
I heard every year the attending on call picks the best intern and lets them perform a
More
procedure
second
during
go.
the first.
There's something really important here though. This was almost a HIPAA violation. That is when you share patient information regarding a specific case to people who are not in charge of that patient. In this case, although it's these two doctors talking, there could be other people who are eavesdropping, other people who are hearing the information. The best thing to do is to conserve patient privacy.
First 2 rounds. This is my year. I could have won. Hello? You're so lost. What are you, like, new?
2 points on this. Point number 1, I can completely relate with the feeling of being lost on your first day, especially if it's a tertiary care hospital and especially if it's a huge tertiary care hospital. It took me maybe even more than 2 weeks to know everything about that hospital, so it's a learning curve, definitely. Point number 2, and that's where this is not really that medically accurate, doctors don't do everything to their patients, so they don't take them to the labs, then back to their rooms. Medicine is really about being a team, and there are a lot of team dynamics. There are doctors, nurses, social workers, physical therapists, so on and so forth. Basically, it's more about being a team. It's not the doctor that does everything.
Okay, so I'm just gonna insert my fingers into your rectum.
Fingers? Just one finger, the index finger. You don't need to insert your fingers in the rectum.
Nope. Out. Out.
Bet you missed a lot when you first started out.
Okay, so this is really important, and I think this scene They added maybe just to show the dynamic between these two doctors. However, you could learn a lot from this scene. Namely the fact that whenever a mistake happens or whenever someone doesn't understand something, we should really praise that moment instead of just making fun of someone. The reason being is that within that mistake or within that misconception behind a concept, you have a chance to teach someone and for that person to grow. So those moments really should be savored and should be used to help the person understand what went wrong and how they can avoid doing that in the future. Unfortunately, sometimes those learning opportunities go wasted, and it breaks my heart every single time I see it get wasted, because I love teaching, and I think that the more we teach, the more we can reduce mistakes from happening, the more we can grow together, the more we can learn under each other's wings, so on and so forth. So a part of my heart just broke after I saw this scene.
Our doctor at home said that she might need an operation. Is that true?
What kind of operation?
She's, well, you know what? I'm not the doctor. I'm a doctor, but I'm not Katie's doctor, so I'll go get him for you.
100% relatable. When I'm taking history and physical from a patient, sometimes they want to ask questions, they want to get reassurance, they want more answers. It creates a very awkward situation because you really want to help, but you just can't. There are a lot of rules for how you should conduct yourself in the OR. This is known as OR etiquette, and before the surgeon got in, he actually needed to scrub all his hands all the way to the elbows, and there's a very thorough process for that. Once he's thoroughly scrubbed his hands, he needs to actually go from the sink outside the operating room to the operating room without touching anything with his hands. Then he'll dry his hands, put on the sterile gloves and the gown. Even when he's wearing the gown, he's not allowed to put his hands near his laps. If he wants to rest, he could leave them in his chest, or he could raise them as seen here. This is all done for a very important reason: to reduce the chance of infection reaching the patient.
Scalpel.
Fun fact, I've never actually been in an operating room like this where it has another level where you can actually watch the surgery. Every single operating room I went into, it was very difficult for me to see a surgery unless I was the person that was scrubbed in and retracting.
Scalpel. Appendix is out.
Someone please time that and put it in the Guinness Book of World Records. That was an insanely fast appendectomy. It is usually a very quick operation, something between 20 to 30 minutes. Some surgeries take hours. A surgery could even last up to a day. It just varies from surgery to surgery.
Finished first in our class at Stanford.
I am really happy that they put doctors here eating from a vending machine, because it is really what's been going on, not only in hospitals, but even in university libraries. I'm even guilty of this. When I was studying for my board exams, I would sometimes stay in the library up till 10 p.m. So most restaurants in the university have closed by then, so the only place you can really get food is from the vending machine. So it really kept me going for an extra hour or two.
Took you long enough.
You're okay? The nurse paged me 911.
I had to go all exorcist to get her to even pick up the phone.
Wait, there's nothing wrong with you?
I'm bored.
You little...
Although this is very comedic, on a serious point of view, patients do get very upset and they do get bored, and sometimes even they get depressed. So this would be a good chance to get a social worker for the patient. Social workers are really just forgotten sometimes by doctors, but the mental state of a patient is really important, and to keep them happy within the hospital is really going to go a mile to letting them live a happy and enjoyable life.
Start a central line.
So start one. You don't know how.
I've never done one.
Well, you know what that means.
Believe it or not, you do not need to ask your seniors to show you how to put a central line in. The best person to ask would probably be a nurse. And if you've been nice to everyone on your team, especially nurses, they'd be more than happy to show you and possibly teach you how to get a central line.
Got post-op pneumonia. Let's start antibiotics.
Are you sure that's the right diagnosis?
Well, I don't know. I'm only an intern. Here's an idea. Why don't you go spend 4 years in med school and then let me know if it's the right diagnosis? She's short of breath. She's got fever. She's post-op. Start the antibiotics.
This scene actually has a lot of elements that I could talk about, and I'd like to approach them one by one. So point number one, arrogance and medicine, they pretty much don't mix. So if you have an attitude or if you're arrogant, I'd really suggest you try out any other specialty than medicine. Point number 2, you always respect every single person on your team. Just because you're a doctor and you did 4 years of medical school doesn't mean that you're better than someone. You can always adjust for a lack of knowledge by learning more, but a lack of respect is something that you can't change for a very, very long time. Point number 3 is that sometimes doctors are so fixated on their diagnosis that they forget any other diagnosis that's possible. Here, for instance, this intern thinks that this diagnosis is pneumonia, which is a lung infection because of the fever and shortness of breath after an operation. It is a very common issue that can arise after an operation. However, there are other causes of fever and shortness of breath after an operation that this intern isn't considering. Not only that, but they are incredibly dangerous as well. One that comes to my mind is pulmonary embolism, which is when the clots in the blood vessels of your legs actually travel all the way to your lungs, can cause immediate death. There is actually a list of different causes, and just jumping to pneumonia and starting antibiotics without getting any investigations to prove your diagnosis is just lazy. And this brings me to the last point, point number 4. Evidence proves your diagnosis, not a degree. Just because you have 4 years of medical school does not mean your diagnosis is correct. Your diagnosis is correct if your evidence suggests that it's correct, meaning that you get investigations that prove that this lady has a pneumonia.
Okay, she's full on the lorazepam. She's had 4 milligrams. You page Dr. Bailey and Dr. Shepard.
The Razepam's not working.
Phenobarbital. Load her with phenobarbital.
Alright, so this is a huge mistake. You do not just say load her with phenobarbital. There's something called closed loop feedback, which means that you need to give the name of the medication, the exact dose that you need to give, the route, meaning is it going to be intravenous, intramuscular, is it per oral, per rectum, so on and so forth, and the time. So is it stat, across 5 minutes, so on and so forth. Then once you give the order, you don't just immediately administer it. The nurse who's going to administer it actually repeats that order back to the person who orders it. Once the order is absolutely correct, only then do they administer it. You don't just say load her with phenobarbital, especially when you're treating seizures, because, well, the doses are really important when it comes to seizures, you know, and an incorrect dose could actually just outright kill the patient. Oh no.
Charge pounds to 200?
No.
Clear.
Still VFib, nothing.
I am absolutely distraught over how wrong this scene is. Now, this patient has entered asystole. It's when you hear that heart monitor sort of go like beep. That means that the patient effectively flatlined, effectively they're considered dead. What you need to start doing is chest compressions. Chest compressions is what saves lives. The sooner you do it, the better. They immediately, instead of doing chest compressions, jump to the defibrillator. Now, I know in movies and media, they see that when the heart stops, they have to go shock the patient, but that's actually a misconception. You don't shock every single rhythm. You only shock certain rhythms. In this case, you never shock an asystole.
He'll be fine, right?
Tony's gonna sail through.
You have nothing to worry about.
Promise.
Never give false promises. We all want this patient to survive. We all want this patient to have a good outcome in the surgery, but sometimes that's not in our hands. Surgeries have risks, and sometimes those risks are out of our control.
Katie competes in beauty pageants.
I know that, but we have to save her life anyway.
Okay, she has no headaches, no neck pain, her CT is clean. There's no medical proof of an aneurysm.
Right.
Remember when I said earlier that this was almost a HIPAA violation? Well, this is definitely a HIPAA violation. You have no business talking about patient details when you're in the middle of a hallway, much less in an elevator. Do not talk about patient data. Respect patient privacy.
Wow, that was quick. His heart had too much damage to get him off the bypass. I had to let him go.
That's why you never give promises.
Rarely, but it does happen. The worst part.
Gloria, there were complications in the surgery. Tony's heart had a lot of damage. We tried to take him off bypass.
You never, ever, ever do this sort of conversation in such an open setting. There is an absolute art to breaking bad news. This is not how you break bad news. You do not do it in the open, and you do not just surprise patients with the fact that their father or their husband or a family member just up and died. Instead, you invite the patient over to a private environment. You ask them what they think the problem is. You offer to them how much would you like to know, and then when they give you the answer, you reveal the information to them. And this is probably the most important part. You give them a chance to pause and express their emotions. Doesn't matter if you stay silent for 5 minutes to 15 minutes to 30 minutes. Give them a chance to express their emotions. Once they had a chance to recollect themselves, only then do you actually proceed with any follow-up questions.
I had a lot of patience last.
Name the common causes of post-op fever.
Yes.
From your head, not from a book. Don't look it up. Learn it. It should be in your head. Name the common causes of post-op fever.
The common causes of post-op.
Can anybody name the common causes of post-op fever?
Wind, water, wound, walking, wonder drugs. The 5 W's.
Man, oh man, the 5 W's. You have no idea how happy I am that she used the mnemonic. In medicine, we have a lot to learn. A lot of it revolves around understanding, and also a lot of it revolves around memorizing. So sometimes we try and ease the process of memorizing by developing some nice mnemonics. The most famously known mnemonic in all of surgery, in my opinion, is the 5 W's, which lists the common causes of post-op fever, like she mentioned.
Especially if you're too busy to do the tests.
Ugh, that look is not the look you want from an attending. Alright, and just like that, we have finished our first episode of Grey's Anatomy. I really hope that you found this video enjoyable and beneficial. If you did, please consider supporting me by hitting the like button and subscribing to never miss any of my future content. If you'd like me to react and break down some medical scenes from your favorite shows, then please leave your suggestions in the comments. I always read the comments and I respond to them whenever I can. As always, thank you for watching, and I'll see you in the next one.